Good afternoon, everyone. My name is Sanyukta Mathur. I'm with the Population Council. I'm the Evidence Utilization Lead for SSLN I2I, and we're really glad to welcome you to this session. We're going to be talking about HIV prevention cascades and hopefully how these can be useful to you in your programming and your work. Just starting off if you could go to the next slide, please. Just some housekeeping. We really want to know who's here, who's in the room. Please, if you could introduce yourself in the chat by sharing your name, where you're joining us from, and the role, especially if you're using data or are involved in precision programming in your role. We are hoping for this to be an interactive session. So unlike a webinar, we would like for you to raise your hand, share your thoughts, put comments or questions in the chat. We would prefer if you could please keep your microphone muted unless you're speaking, so we avoid any disruption, during the presenters or participants. And rest assured that the session is being recorded, so we will share this back out with you all after the session, and the information will be uploaded to the SSLN website. Next slide, please. Great. So let me walk you through a little bit of how we're going to spend the next just a little more than an hour and a half or an hour and a half. So we are going to start first. My colleague Vidyate is going to give you an overview of the HIV prevention cascades guides that we've prepared and do a little live demo as part of that. You'll get to hear two country perspectives then, one from Kenya and one from Zimbabwe, about how they have used HIV prevention cascades. So we're really excited to welcome Dr. Lily and Dr. Irene and Mr. Norai to the group to share their experiences. But some of these tools can be really complex to use. So we want to we're going to have breakout sessions, one for each of the 4 tools that are included in the HIV prevention cascade. So you can engage in a little more intimately with these tools and ask questions about how they're developed, think about how they could be used in your context. So I hope you'll join us for that. We'll wrap up with some feedback, Q&A, and just some closing remarks. So I hope this sounds good to everybody. And without further ado, let me just go into providing a brief background on HIV prevention cascades and sort of why we're here. So as the agenda kind of demonstrates, we're going to introduce this guide. We're going to share understanding of the 4 cascades that are included in the guide: the basic UNAIDS cascade, the effective program coverage cascade, the combination prevention cascade, and the prevention to treatment cascade, and somehow they're practically applied. We're going to share implementation evidence from Zimbabwe and Kenya on using these cascades, and understand country-specific data needs and upcoming opportunities for you to use these cascades. Next slide, please. Why do we need cascades? Well, we're still grappling with an expansive HIV epidemic. Over 1.3 million people acquired HIV worldwide in 2024. We are far from the targets we need to end the epidemic. And given our current environment, part of this closing this gap requires prioritization and data-guided decisions to improve national responses and monitor results, especially when resources are tight. So some of the efforts around precision programming can help individuals like yourselves target and reach the right populations with the right interventions at the right time. However, figuring that out continues to be a challenge. Next slide, please. So HIV prevention cascades really serve as a powerful tool for database decision-making and enabling precision programming. So cascades are structured frameworks that visually present how individuals or populations move step by step through a series of health services or interventions. In HIV prevention, they're used to track progress from awareness to consistent correct use of prevention methods. They can either focus on individuals or populations, helping programs reach people who are often missed and improve overall effectiveness. They can also reveal gaps in prevention efforts and track program performance over time, and guide ultimately guide resource allocations to improve those outcomes. So interest in the Cascades work has grown, but there are multiple sort of ways of developing Cascades, and choosing the right one and knowing how to populate it requires careful consideration. And this is what brings us here today. Next slide, please. So without further ado, I want to hand over to my colleague Rade Gabrewat, who has taken a lead in developing the HIV prevention Cascade Guide, and she will provide an overview as well as a demonstration. Rade, can I ask you to join, please?
Thank you, Sanyukta. Good afternoon, good morning, everyone. It's a pleasure to be with you today. So in this part of our session, I'm going to provide a high-level overview of what this new tool includes, followed by a quick live demonstration on how to show you how to navigate this interactive guide to the HIV prevention cascades. Next slide, please. So to follow along with me while I do the demonstration, or to explore the guide on your own device, you can simply scan the QR code displayed on your screen. You can also use the link that the team is dropping on the chat right now. So for future reference also, you can find this guide fully accessible to download on the resource section of the SSLN website. So I'm going to give a few more seconds for everybody to be able to scan, or go to the link in the chat. Okay, next slide, please. So the guide to HIV prevention cascades is specifically designed to improve precision of program planning and implementation across countries. Many countries were introduced to the general concept of HIV prevention cascades. However, there were often uncertainty about how to distinguish between the growing number of existing approaches. So this guide was created by I2I to SSLN I2I to address this and provide a clear, standardized path forward. Because the HIV response requires a multi-sectoral collaboration, the tool is intentionally designed to support different stakeholders in achieving their specific national objectives. So, for example, policymakers and funders can use it to set realistic national targets and drive high-level advocacy. Program managers can deploy it to monitor local implementation progress and inform decision-making. Research and academics can use it to align their studies with standardized operational definitions, and clinicians and healthcare providers can utilize it to identify where patients are falling out of care at the facility level. Next slide, please. So while many variations of prevention cascades have been proposed so far, this guide focused on the 4 primary models most commonly used in practice today. And this include the first one is the UNAIDS Basic Cascade. This examines how many individuals are reached by prevention methods, keeping a close eye on reach, coverage, uptake, and general usage within the specified population group. The second one is the Effective Program Coverage Cascades. And this approach assesses how many people were effectively covered by a prevention method, utilizing a program science approach. The third one is the HIV combination prevention cascade. If you're trying to, as a program manager, to understand the why behind your program drop-offs, the CPC cascade can provide that insight because it investigates where and why individuals drop out of the prevention cascades by systematically evaluating program effectiveness. And the last model is the HIV continuum of care and treatment cascade. This provides a system-wide perspective. It tracks individual engagements across the entire response system, creating a visible link from primary prevention all the way through testing, clinical care, and long-term treatment. Next slide, please. So for each of these prevention cascade approaches, the guide provides a standardized indicators, definitions for numerators and denominators, required data sources, step-by-step instruction for adaptation, considerations that must be explicitly called out, that calls out the unique strategic advantages and data collection challenges of each model, and finally, real-world application of the cascades. Um, Next slide, please. So basically, this is what the tool contains, but just I'm going to provide now a live demonstration. So please, Tony, if you can stop sharing, I'll go to the tool directly and show you how to navigate this tool. You put it on. Okay. I hope you see my screen in full mode. So this tool is built as an interactive, user-friendly PowerPoint format that allows you to navigate seamlessly across sections with a simple click. At the beginning, we have embedded a feedback survey link, and we highly encourage you to use this to share your user insights because participant feedbacks directly guides our continuous improvement of the tool. As you click through the first few slides, you'll find introductory slides where there is a user instruction on how to optimize your navigation experience. We've also, before jumping into each of the cascades, we've also included a brief background to orientate new users on exactly why prevention cascades are vital and to map out specific stakeholders. The next main section transitions directly into describing what each cascade tracks and when it is most helpful to adapt and populate to make sure that the user interface is intuitive. We have made this color coded, so each color is aligned with one cascade, which allows you to explore different models by clicking through some dedicated buttons. So this is the main cascade library. Consider this your main hub. From this single page, you can jump directly into whichever cascade model that you are interested in exploring. Because the structural layout is perfectly mirrored across all 4 cascades, navigating one means that you can navigate them all. So for example, if I would like to go to the UNA's basic cascade, I simply click through this and it should take me to the UNA's basic cascade. Same for the other cascades. So if you go to one cascade, you'll notice 4 different buttons at the top. This allows you to explore the different cascades in more details. And if you're exploring one cascade and you'd like to see another cascade, you can just simply go through these buttons in your top right corner to simply jump from one to the next. And at the bottom here, you'll see a button that takes you back to the main cascade library. And then you can choose another cascade to explore. So I'm going to click through one cascade and take you through the elements that it has. But like I said, because it's similar across all cascades, it is the same for all the others. So let's click into the UNA's basic cascade as an example. So if you want to explore the specific elements of this basic cascade, you simply click through the corresponding buttons to unpack the indicators, steps for adaptation, considerations, and data requirements. And you can do this by a simple click into those buttons. And it should take you to right where you want to be. We have included some considerations for each of the cascades, which allows you to understand the advantages and the limitations for each of the cascades. And you'll also find a data requirement where you'll find the data sources that's needed to adapt and populate these cascades. And where possible, we have embedded direct hyperlinks within the data requirement section to connect you to further external resources on those specific data sources. And they have been underlined here, so it takes you to an external resource. Finally, it will also give you a country application, and this gives you a real-world practical examples of how specific cascades were populated and adapted at a national level. At the end, so this is all the same for the slides. Let me quickly run to the end. So at the end, you'll also find a cascade summary of the four cascades that were discussed in the tool, including the focus, the unique advantages and limitations, and the general considerations that should be thought of when adopting and populating these cascades. So I won't dive into the specific of each individual cascades right now because we have an exciting interactive breakout sessions coming up where you get to explore each of these components in each of the breakout rooms in depth. But I hope this demonstration of the tool is clear.
Thank you,
And
Renee.
yeah, over to you, Sanyukta. Thank you so much.
Thank you, Renee. That was excellent. Colleagues, there is a comment from our colleague Lamek in the chat. You can access all the cascades in English, French, and this cascade guide in English, French, and Portuguese. I know this session is in English, and I apologize for that, but the guide is available in the languages that SSLN operates in, so I hope you'll engage. I'm happy to switch now so that you can hear from our country colleagues to really understand how they've used prevention cascades in their work. So I'm excited to welcome Dr. Lynn Nyaga and Dr. Irene Mukui, who are going to talk about closing the gap of prevention cascade analysis for key populations in Kenya. Next slide, please. Let me tell you a little bit about Dr. Irene and Dr. Lily. Dr. Irene is a physician and she's a global health expert and implementation science researcher. She's currently a PhD candidate in implementation science and health metrics at the University of Washington in the United States. She's the former head of HIV at DNDi. For 8 years, she led Kenya's National HIV Care and Treatment Program, and she's a former WHO HIV Drug Resistant Network co-chair. Welcome, Dr. Irene. Dr. Lily is the lead strategic information and research unit with NASCOP in Kenya. She's the co-chair of the Global HIV Surveillance Technical Working Group. She's a physician and has degrees in applied epidemiology. She has worked on HIV surveillance, strategic information, epidemiology, data system, and implementation research for over 15 years. Welcome, Dr. Lily. And I'd like to pass over to you to lead us through your example, please.
Thanks, Sanyuta. And thanks for the kind introduction. So I'll do the presentation on behalf of the team. So if you can take us to the next slide. Yeah, so this work we did jointly with Dr. Lily, having previously worked together, but also to mention that I think Kenya was among the first countries to adopt the HIV treatment cascades. At the time I was working on HIV treatment, so and we saw how that helped improve programming and how that has become part of routine data use and to inform programming. So when we saw the opportunity with the SSLN, we sort of decided to replicate the same, and increasingly the use of prevention cascades was coming in. So part of the reason why we decided to do the analysis is that when you look at the HIV prevention epidemic in Kenya, although the key populations form a very small proportion in terms of the overall population, they actually contribute significantly to new infections. So 30% of new infections in the country occur among key population groups, including female sex workers, men who have sex with men, people who inject drugs, and transgender persons. We also have increasingly as a country been collecting routine data. However, this is not necessarily used to break down prevention data in a way that it informs us where people drop off along the cascade of HIV prevention services. So a lot of the data that we tend to collect tends to give us information about uptake or reach, but usually we don't have information about how many people are persisting in specific services, and that doesn't occur across the cascade of care. So we had the advantage of the country having conducted the biobehavioral survey in 2024, which was very timely. across 9 counties, and we utilized that data to construct cascades of care. Initially, our idea was also to use the health information system, the routine HMIS data, but that was not possible because of gaps in key indicators that would inform the prevention cascade. So with that, we went ahead and planned to develop the HIV prevention cascades using 5 indicators, targeting 2 key populations that were the focus of the BBS survey. And our intention was to be able to look at the cascade performance, disaggregate data by county age and the different typologies, and then eventually develop visualization using Power BI dashboards to inform routine programming and also allow gap identification. So next slide. So we have used the effective program coverage, and I'll just quickly go over the steps, which I know we'll cover again in the breakout sessions. So it has 4 key steps and starts with availability, which means whether, and the effective program coverage pretty much wants to measure the proportion of the target population that has effectively been covered. So the key steps include availability, which means whether the services are available, where people can actually access them, and we look at the indicators that we used to compile these. And then the contact cascade, which wants to look at whether people have been able to reach the service within the past period of time. For, in our case, a lot of the indicators we used 12 months. And then utilization, and which looks at whether the population that is of interest access the service at least once within the window that we were looking at, and then the adherence, or which looks at the service, whether people consistently used the service. We ended up using the first 3 steps, mainly because we didn't really have a lot of data to look at the adherence components. So next step. Next slide, please. So as I mentioned, our data was the 2024 biobehavioral survey, which was conducted between March and June 2024 in 9 counties among female sex workers and men having sex with men. We conducted secondary data analysis applied to the biobehavioral survey. We looked at 5 prevention areas, that is condom use, HIV testing, use of pre-exposure prophylaxis, STI screening and STI treatment, although we had a lot of limitations with the kind of data that was collected for the STI components, and therefore we acknowledge some limitations. And we looked at the 3 different steps, and I think to some extent we've looked at adherence, although we had gaps in the data for measuring adherence. Next slide. So we'll just give you an example. We did both at the national level coverage, which is consolidated, plus we've also drilled down by age groups and also by county. So we'll give you a snapshot of what we found at the national level and also some of the geographic differences. So for example, this is the HIV testing cascade among the female sex workers. The total number of persons who were surveyed formed our denominator across the different indicators. So when you look at the required population, that's where you see 100% based on that. So when you look at the second step for us for the availability, for HIV testing, we used ever tested, and that's because of the data that was available by the BPS. But you can see availability across the HIV testing, the condom use, the pre-exposure prophylaxis, the STI screening, which is slightly lower. But when you look at the first 3, you find that we have high availability of services across board. And this applied also across the key population groups and also by the different service points. However, as you look at the cascades and go down, you start to see there is a drop as people move to the different components of the cascade. So for example, for contact testing, that drops to 85%, although it's still reasonably high. For condom use among the female sex workers, you see that the contact drops to 68%. And when you move to the use of PrEP, again, that drops to the 50s. And the last component, which is looking at utilization, which looks at whether people are persistently using, usually as per the guidelines, then that's where we have the largest gap, and that covers across all the different service prevention areas. As I mentioned, we were not able to create the last step for STI screening and treatment because of the kind of data that we had. Next slide. You see the same thing with the prevention cascades for the men having sex with men. One of the things that we noticed is that when you look at compare the data with among the female sex workers, is that you see significantly higher drops as you go down the different steps of the cascade among the MSMs, especially with the condom use and also the pre-exposure prophylaxis. So next slide. So when you look at the age group distribution, this is the thing that you start to notice. So for example, again, availability is quite high, but it tends to vary. This is data, for example, if you look at the last step of the cascade, which is the utilization cascade tested within the past 3 months, and compare across the different age groups, we looked at 15 to 19 years, 20 to 24 years, and 25 years plus. Slightly higher utilization in the 15 to 19 years and slightly lower proportions within the older age groups. And then when you look at the female sex worker condom use, again, you start to see differences in the different subpopulations. Next slide. So we also found differences across the different counties. As I mentioned, we looked at 9 different counties, but also for the different counties, we had some of the subpopulations that were not covered. So among the FSWs in the 15 to 19 age category, you see for Kisumu, which was one of the counties, very high coverage for across the different steps of the cascade for HIV testing, and then you start to see differences. One of the things that we noticed is that when you compare urban counties or urban areas where the survey was conducted, plus more of the moving to the, I would say, semi-urban and the rural counties, then you start to see larger drops in the coverage of the different steps of the cascade. Next slide, please. So we did dissemination to stakeholders. One of the things that we did from the beginning of this work was to involve key prevention TWG members, which includes program managers, implementing partners. We had funding agencies and county AIDS coordinator who were involved at the very beginning when we were formulating the idea. We also had presentations done to the key populations prevention technical working group and also the NASCOP prevention leadership. In terms of and these were engaged not just at the beginning, but also when we were finished with the development of the cascades. We developed a number of dissemination products. We developed a policy brief that you can see on the right-hand side, and this was shared with the National AIDS and STI Control Prevention Managers. We also made PowerPoint presentations to the prevention technical working groups, and also the prevention cascade dashboards have been integrated into the national dashboard platform where we have other dashboards. Next slide. Just to quickly mention some of the lessons that we have learned and recommendations for the future. So we were able to develop BBS, using BBS data to successfully develop prevention cascades. However, as I mentioned, in several of the areas, we lacked questions that directly translated to the steps of the cascade, and therefore we had to do some adaptation or use proxy indicator. For example, we used HIV testing availability. We used EVA testing as our indicator to denote availability. Across the different steps of the cascade and the different testing services, sustained use towards the end was one of the weakest links that we had. And this is the step that matters the most to make sure that interventions are effective as intended. We also found the national average tends to mask wide variations by subpopulations, but also by geographic regions. In terms of what we intend to do in the future, and I guess an overall recommendation is during the dissemination meetings and discussion with the different stakeholders was the obvious gap in lack of understanding for the cascades and also just the utilization of the cascades. So there's need to have policymakers, program managers, and different stakeholders understand cascade for their use for decision making. One of the key lessons we learned is that in future BBS studies, we may have to redesign how we ask questions if we intend to continue using this data for developing cascades. Next slide. We have had the cascades used for different purposes. We had a recent meeting with the HIV prevention team at NASCOP, and therefore the current ongoing Global Fund grant, Cycle 8 grant writing, is looking at the cascade data and utilizing this, especially for the counties that were covered in the development, which is really exciting to see this level of utility. We also look forward in terms of the future, starting with the Global Fund grant for especially with the current funding reductions that we have, the cascades being utilized to guide budgeting and resource allocations, and especially to support the later steps of the cascade where we see large drop-offs. Also to integrate the use of the dashboards in the county and sub-county reviews to track progress. And hopefully in the future, we are able to get more data to cover more counties, and obviously to use this for sessions like this for peer-to-peer learning. I think that should be the last slide, if I'm not wrong. And thank you very much. We look forward to participating in the breakout sessions. Over to you, Senator.
Thank you, Dr. Irene. That was excellent. I really appreciate how you walked us through the purpose for doing that, the considerations and challenges that you faced, and the impact you've had. I love that you noted that the cascades have helped you figure out where services, where people were being lost along that pathway, and reiterating the point that you made that engaging the wide variety of stakeholders early and throughout the process really has helped have some of the kind of use and impact that you've seen. So that's wonderful to hear. Colleagues, Dr. Irene and Dr. Lily will be with us. They're going to be joining us for the interactive breakout session, so I know you'll have questions for them. So either put them in the chat or hold them and join us for that session for the effective program coverage cascade small breakout group. Before we go to that, though, we'd love to hear from Zimbabwe. And I want to invite Mr. Norai Sitol to present the Harare HIV prevention, combination prevention cascade and his experiences there. Next slide, please. Mr. Norai is the Strategic Information Coordinator with the Ministry of Health in Zimbabwe. He is a monitoring and evaluation expert with over 14 years of experience. His background is in a range of HIV and AIDS projects, and he has been responsible for the coordination of strategic information activities within AIDS and TB programs. He holds a Master's of Science in Population Studies, as well as Monitoring and Evaluation, and a Bachelor of Science with Honors in Monitoring and Evaluation. Mr. Norai, please join us.
Thank you very much, Chair. Well, I will actually, sorry, here and there, I'll just put my video, then I can actually switch off because I'm having internet challenges where I am. I'm not in the office. So I think I'll go through the HIV, combination prevention cascades. Of course, you can actually see that we also got, support as we were doing with the, Imperial College, studies that are also being done in Zimbabwe, particularly in one of the provinces, which is Manicaland. So I would like to acknowledge as well as the National AIDS Council for Zimbabwe. So let's move on. Right. So I'll actually start with what is the problem that really, made us, develop these, combination prevention cascades. I know, from the first introductory lessons where we have actually seen that most of our cascades will rely mainly on routine program records. Of course, they've got advantages since they are actually designed, for any program approach, and it can be measured over a short time of period using program, monitoring data as shown by the examples that I've actually shown there for female sex workers on PrEP, how many are target, reached, tested for HIV, etc, etc. So these are the basic, I think you also saw the basic, units, cascades using, program data. So that's the problem, that we are just, using these ones as to strengthen our programming. So why do we have to now extend this to other cascades? Let's move on. So we said, however, these cascades using program data are not suitable for other imported uses. As you can actually see those, bullets, especially for providing high-level overview, gaps in the overall use of HIV prevention methods. What are the gaps? And why are the gaps? So these routine, cascades cannot give you that information. They're not useful. They also cannot give you robust information on coverage, using, information that is not captured on all the people who take up the services. You just say how many have taken up the services, etc coverage, but not much information can you get from these, routine, cascades that we use as we actually implement our programs. They cannot also provide information as to reasons why people are not using, HIV prevention methods. For example, some people can say, why is it that, condoms are available, but the uptake is quite low? So these routine, cascades will not give you that information. Then there is also issue of comparison with other countries and programs as part of evaluation program performance for reasons given. I think in cases 1 to 3, you cannot actually not compare using these routine, cascades that we normally use using program data. Thank you. Let's move on. So what's the solution? So for these use cases that we've actually, explained, or that I've explained, HIV prevention cannot measure, can be measured periodically using data collected in national population surveys. Cascades can take different forms, and one single standard formulations need to be adopted in surveys for these use cases. So the Harare HIV prevention cascades was developed for these reasons, that we have actually identified these gaps, and we actually made use of HIV combination, prevention cascades. So within this presentation, I'll describe in terms of measurements for the core cascades to be made using the population surveys. Because in Zimbabwe, I think for the first time, we've actually managed to make sure that within the ZDHS, or the Zimbabwe Demographic Health Surveys, we managed to make sure that, combination prevention cascades are also included. I think this is a milestone that other countries can also adopt or copy or replicate, so that at least we can actually see that the combination prevention cascade can give us more information in terms of the uptake of different prevention methods. Let's move on. So we have got 2 levels, in terms of these combination prevention cascades. We have first one, the core cascades, suitable for use cases of 1 to 4 above. That we have explained those uses. Then we also have an expanded cascade. So this expanded cascade will also build upon these core cascades that we have actually, that I'm going to explain now, really explaining the reasons as to why we are not having people using different prevention methods, so that it will inform identification of specific interventions which are needed in order to close those gaps. Otherwise, we can actually say people are actually motivated to use these particular methods. They are not motivated. But now for us to be able to explain the reasons why people are motivated, reasons why people are not motivated, reasons why people are not using a particular prevention method, we use the expanded cascades. Let's move on. So this is an example of the core cascade that has actually been used for Harare in order to really measure reporting and comparison across countries to support the prevention methods, in order for us to be able to achieve the 95% coverage, the UNAIDS, targets. So we can actually measure this one in national population surveys. We can compare results across countries. We can track and report progress against preset international targets. I know if you look at the left-hand corner side, where we have the first bar, which is the priority populations that we are actually focusing on. It could be adolescent girls and young women. It could be female sex workers, etc. So the second, bar tells us those who want to use that prevention, how many people want to use that particular prevention methods. That's the second bar. Then third bar is say, out of those that are motivated to use that particular prevention method, how many of them are able to access that prevention methods? Then last is those effectively use, out of those that can access, how many of them effectively use that particular, HIV prevention methods? Then the below one is now subdividing, these bars. The blue one is indicating that priority population, and out of those that are motivated to use, then we subdivide again to say which particular prevention methods are they motivated to use. As we go on, access, which ones are they able to access? Then last, which prevention methods can they effectively use? So this is how, the cascade in terms of the core is actually arranged or developed, as we were actually doing the Harare combination prevention cascades using the core cascade, platform. Let's move on. So this is just, in an illustration of what I was talking about as we are moving with all these, bars. Let's move on. The same thing, I think this one, there was also a study that was done in one of the provinces in Zimbabwe, Manicaland, where this is real data to say, if you look, there are 211 people, in which was the priority population, and 133 were motivated to use the particular, and 60. So we are seeing the bars are getting, smaller and smaller. So it means as we move on, we are going to find out that why is it the bars are getting smaller, and out of those, prevention methods, which particular prevention methods and how many people, what proportion are able to motivate to use that particular prevention method, and how many can access it and effective use. Like for example, this one, you can say the male condoms only is the one that has been effectively used out of all other prevention methods. So as we move on, we need also to say, yes, this is the information, but we need more information to explain why there are variances in terms of the size of the bars as we move. Let's move on. So in terms of now the extended cascades, we've talked about the core cascades where we talked about issues of motivation, access, and effective use. We now need to understand where are the gaps between the bars as we collect this data. What are the reasons for the gaps? And that review the combination of multiple level intervention need to increase effective use of this, because our aim is for us to be able to make sure that people use these different, prevention methods. So we broke down the main Harare prevention cascade by method and use these extended to identify the most common factors contributing to these gaps along the, the continuum of care, and also draw from literature to identify interventions that are more effective in reducing the factors, contributing to these gaps. As you can actually see that, from the priority population, which is bar graph, bar number 1, out of those that are motivated to use these particular prevention methods, why do people lack motivation? What are the reasons? Then we need also to find out to say, both from literature and also from surveys, asking people, why are you not motivated to use these particular prevention methods? Then the possible interventions, that's now we can get from the literature to say, what are the possible interventions that can actually be implemented in order to make sure that that gap is bridged. Then access, the same thing, the reasons. We also explain interventions and those that effectively use this particular, preventions, why they lack the capability to use. What are the reasons? Could it be, that, these people, are the partners? Like, for example, if this is a female condom, is it due to the partner influence, etc.? And what are the possible interventions that can actually be implemented for us to be able to really increase effective use of this primary HIV prevention method? So the issue is about the gaps and reveal the reasons why we are having such gaps in terms of uptake for these different prevention methods. Let's move on. So these are examples of data or graphs that we actually managed to incorporate in the 2025 Zimbabwe DHS, where we have, these bars, where we have, for example, ages 15 to 49, females who are sexually active in the last 12 months. On the right, males sexually active in the last 12 months with 2+ partners. So you can actually see that, from the study population, that these are the numbers. And as we move along, the bars in terms of access motivation, you can actually see that for females, you can actually see that those that effectively use are very low as compared to, to male counterparts on the right-hand side, maybe because males, due to issues of having 2+ or more than 2 sexual partners, that's why they are effectively using a particular prevention methods, which in this case could be condoms, whatever the case may be. But now for females, maybe they will be in a stable relationship. That's why at times they might not be using some of these HIV prevention methods, as you can actually see. So this is an extract from the Zimbabwe Demographic Health Survey to show that we've also managed to input this information for combination prevention co-cascades within this, survey. Let's move on. Then this is also another example of specific HIV prevention co-cascades that we also, was incorporated. We know there are several, but these are some of them. The PrEP, amongst those that are sexually active, as well as male condoms. You can actually see that, for PrEP, from the priority population, as we move, to the right-hand side, the motivation seems to be very low. Those that can access is getting lower, and effective use, maybe because we are still, access, whatever the case may be in terms of prevention, what could be the reason? So if we are seeing such a scenario within these cascades, then we should be able to ask ourselves to say, why is it that if PrEP is available and people are not effectively using this PrEP, what could be the reason? That's now from the co-cascade, we go to the extended, finding the reasons, reading the literature, interviewing people as to why they are not using this particular. So now we have robust information in terms of what, the use in terms of this one. Male condoms, you can actually see that the bars are quite high, showing that people are actually using more condoms as a prevention methods than PrEP. So we'll be able to compare, these, bars or graphs using the co-cascades, and we've managed to incorporate them as I've alluded to. Let's move on. Again, I think you can also, so these are females as well. So if you are comparing amongst different, population, to say for females, you can actually see that the bars are not quite, as big as those of their male counterparts. Then you start to say, okay, for females, PrEP, this for sexually active, this is the situation in terms of motivation, access, and effective use, condoms, this is the situation. So we will actually, the explanation is the same. We need to now to dig down to say what could be the reason as to why these bars are, there is a very big gap between first bar and second bar and subsequent bars. Then be able to proffer those explanations, and we make our interventions to address those gaps. Let's move on. So in conclusion, I think, HIV, combination can provide critical information evaluating our progress as we are implementing, HIV prevention, programs, finding gaps. So we also encourage, other countries, for them to be able to adopt, these, cascades using surveys and guidelines so that they're also included. You can ask, from different, partners who support, prevention. You can also incorporate this in DHS and other national surveys so that at least we measure, our prevention, our combination prevention, programs, so that in the next revision of their standard survey modules, they also include such information. Let's move on. So I think we will end here in terms of, I think there were other literatures that we can also share in terms of, graphs and things that we've also included in the ZDHS. But in short, this is the end of my presentation. Thanks, over to you, Chair.
Thank you so much, Ari. That was wonderful. Colleagues, can we have a round of applause for our country presenters? They've presented really interesting information on how they put different types of data together to develop the cascades and really show how it's been used in country. So again, yes, a round of applause for them. And we are now going to move into an interactive section where you can get to ask your questions. Some great questions have already come up in the chat about the kind of data that is being used to develop cascades, the frequency of them. So we want you to come into these breakout sessions and engage. The way we're going to structure this, and bear with us, I hope this will work well. We're going to have 4 breakout rooms. Each is going to be dedicated to a different cascade that is featured in the guide. So please join a room that best aligns with your interests and wherever you'd like to deepen your understanding. So we have one room for the UNAIDS basic cascade. We have one for the effective program coverage cascade. We have one for the HIV combination prevention cascade, and finally one for the HIV continuum of prevention care and treatment cascade. In those breakout rooms, we'll have just a few slides to give some guided discussion so you better understand what's in that cascade and a country example. But then I hope we can really get into some discussion about how this may apply in your context, have a discussion about relevant gaps and challenges, and hopefully some discussion around what kind of challenges or considerations you need to think about if using this cascade and support that you would need in developing something like this. So I'm going to ask my colleague Karabo, do you have any other instructions for the breakout sessions? How will people select? Will a little dialog box pop up?
Yes, so I'm going to open the breakout rooms. A box will pop up on the screen. Please click join. And just a reminder to all the facilitators to please kindly record in their breakout room. So I'll open up the breakout rooms shortly.
Great, thank you. Colleagues, I hope you had some rich discussions in the small breakout groups about the different cascades that were presented, some of the data needs and challenges. I want to open the floor for some group discussion here and would like to take the chair's prerogative actually to pose a question that was asked just at the very end of our breakout room by a colleague on the call about they are situated in a community-based organization, and the question was around how to apply the cascade frameworks, right, or this idea into the work that they're doing. They don't necessarily have access to, for instance, service statistics. So how can the idea of the cascades be applied in their work to do monitoring? Queen Bee, if you're on the call, if I have misphrased your question, please come off mute to say that. Otherwise, I'd like to invite our country presenters to see if they have any reflections on that. How can this be used for community-based organizations?
You definitely nailed the question. Thank you very much.
Okay, good. I'm glad I paraphrased correctly. Dr. Lily, Dr. Irene, Mr. Norai, and colleagues, any thoughts on how our colleagues in community-based organizations could benefit from the perspective of cascades and how to apply them with the kind of data that they may have access to?
Yeah, maybe I can comment. I think even though community organizations may not, for example, have direct access, I don't know, to like data sets or databases, I think the idea of the cascade gives very useful insights, even with interaction with community members that either access services or community organizations interact with. Because at the end of the day, the issue around the cascade is who is accessing services, who is consistently using the services, and who is, and who is keeping to what is required in terms of, for example, when you think about condom use, do community members have access, for example, to, are condoms available in the settings where community members may require them? Are people consistently accessing, and are they using them, in circumstances that may put them at risk? So I think this is useful, and maybe Pari can talk about the specific tools, but I think I think also I consider Cascades as an accountability tool, and therefore I feel that community organizations should probably also in the interactions, for example, with governments and ministries, actually advocate for utilization of Cascades and for them to have access to information that comes out of Cascades, because that way they are able to utilize that information to mobilize communities and also to demand for better access and support services for continuation of services. That's just my thought, but I can't directly answer the question around how, for example, the data access. Yeah.
No, but I think you raised really good points. And Pari, I see you've put a comment in the chat. Did you want to mention the micro-planning tools or the opportunity gap analysis?
Yeah, I just wanted to say that Queen Bee, I think you should look at the micro planning tools that we have, and we use micro planning tools, specifically the opportunity gap analysis tool, which is a different form of cascade, but it is a cascade analysis at the peer outreach worker cohort level. So that's as micro as it can get, and I'm actually trying to figure out and request one of my colleagues to send a link to the micro planning toolkit in our website, and hopefully somebody will post the link. If not, we will send it to you. Thank you so much.
Thank you, Pari. And we can always think about sharing that tool afterwards also if we can't find the link right at this moment. Colleagues, we are right at time. I hope this has been a good and interactive session for you, where we've tried this new sort of virtual kind of learning session. So there's a little poll that has popped up on your screen. I hope you will take a moment to respond. I also want to remind you that all of the tools and materials, the presentations will be shared with you after the session, the slides. The Prevention Cascade Guide itself is available on the SSLN website. So I think the very last slide also has a link to that slide. And we want to hear from you, both about the session as well as about the guide and how it's working for you. Have you used it? Did you try using it and face a challenge? Is there support that you need in filling out in this type of a cascade? We want to hear from you. And with that, I just want to thank you all. And again, another round of applause for our presenters, and to you all for joining us. I know everybody has very busy lives. Karabo, Madonna, anything else from our team, colleagues?
Not at all. Thank you, Sari.
Thank you very much. Please fill out the poll before you leave us.